medicine. Maintaining a patent airway is absolute priority in any emergency situation. During the first minute and primary survey, airway assessment and management are crucial for patient survival. Here is a deeper dive. The airway assessment look. Check the facial deformities, swelling, bleeding, or foreign object obstructing the airway. Listen for pale sound, both normal and abnormal. Stridor, wheezing. Feel for air movement near the mouth and the nose. Evaluate level of consciousness. A decreased level of consciousness can indicate compromised airway function. Use scoring system tools like Malopathy score or Lemon score can predict potential difficulties with airway management. Basic intervention: head tilt, chin shift lift, head tilt, chin lift maneuver, open the airway slightly, jaw thrust maneuver, further open the airway, especially helpful in unconscious patient. Oropharyngeal or nasopharyngeal airway, artificial tubes inserted to maintain airway patent. Advanced intervention: bag valve mask ventilation, manual ventilation using a mask and bag, endotracheal intubation, placing a tube through the mouth or nose into the trachea, surgical circothyrotomy, creating an opening in the throat as a last resort. Important consideration: equipment availability. Different situations may require adaptation with limited resources. Skill level of provider. Advanced intervention like intubation should be performed by trained persons. Skills, very important: continuous monitoring, oxygen saturation, respiratory rate, and other vital signs need constant monitoring. Potential complication: improper airway management can lead to hypoxia, aspiration, and other serious sequences. Ensuring patient protected airway has priority over management of all other conditions, with exception of catastrophic hemorrhage. Failure to identify the need for airway intervention may be as disastrous as inability of pre-hospital care provider to perform the necessary intervention. The following steps should be undertaken to fully assess the airway. Look at the face, neck, and the cavity and the chest. Assess for sign of maxillofacial or neck trauma, foreign body, swelling, blood, paradoxial movement of the chest and abdomen, accessory muscle use, head bobbing in infant, suprasternal, intracostal or supraclavicular recession, tracheal tongue, downward movement of the trachea with inspiration, fogging of an oxygen mask with ventilation. Rule out complete obstruction. Listen for breath sound without a stethoscope. Assess for snoring sound, gurgling sound, inspiratory stridor, absence breath sounds. Difficult airway assessment. The history of and examination of patient can help to predict a difficult airway. Basic airway management. Most patients in the pre-hospital setting have a patent airway. In patients with compromised or threatened airway, immediate action is needed. Here, predicted and difficult airway. History of previous airway difficulties, anatomical abnormalities, visual clues, opening of the mouth, predicted difficult mask ventilation, mask seal difficulty, opacity, obstetric patient, or obstructed airway, no teeth, snore, stiff lung, predicting difficult insertion and ventilation, restricting mouth opening, obstruction at the larynx, distorted airway, stiff cervical spine, surgery, hematoma, opacity, radiotherapy, trauma, air chart, insufficient airway, advanced. We need the skills and the training of the personnel who work with the patient at this moment. Basic training, intermediate training, advanced training. Patient positioning. Conscious patient will generally keep themselves in optimum position to maintain their airway and drain secretion or blood. This position should maintain where possible, and the patient should not be forced to lie supine. Obtended or unconscious non-trauma patients who are spontaneously breathing should be turned into the lateral recovery position to prevent the tongue from falling back into the pharynx and obstructing the upper airway. Section. Correct positioning with posture training is most important than suction in the presence of gross liquid containing of the airway. Foreign body removal, facial fracture reduction, manual airway maneuvers, head tilt and chin lift, jaw thrust, oropharyngeal airway. An oropharyngeal airway or girdle is designed to hold the tongue forward, preventing its posterior displacement that can lead to obstruction of the upper airway. And here the head tilt and the chin lift. Here lateral trauma position. Here nasopharyngeal airway insertion, jaw thrust maneuver, oropharyngeal airway seizing, supraglottic airway devices. Here we find combined US note the safety pin through the NPE. The example of supraglottal airway devices. Clinical assessment and minimum monitoring standard for anesthetic patient. Respiratory rate, pulse rate, capillary lacrimation and sweating. Equipment needed for the safety delivery is personal protective equipment, monitoring, vascular access equipment, drug, suction, oxygen, basic airway equipment, tubation equipment. Common use: ketamine, used drugs, propofol, thiopentone, etamidate, midazolam, fentanyl, and morphine, saxamazonium, zirconium, atrachium.